from the live stream. I hope we are on course. I hope we are doing the best for you. I hope you are understanding whatever we are doing for you. Mm. Any questions so far? Did you see something you didn't understand? Do you have any question? Right. So today is Friday, 29th May. And my name is Paul Bright. Myself and my team, we are here again to give you a comprehensive analysis on pediatric conditions. So we are going to look at pediatric medical conditions. We will take it system by system. So it's going to be like 2-3 days journey. Okay. It's not going to be a rush for you to live this life or this conference with much understanding. Okay. Right. So um let me share the screen. Right. Okay. Thank you, Messi. Thank you, iPhone. Okay. Okay. Right. So this is pediatrics. We've done the basics. Our baby is born. Over the past few days, we look at from day 0 to the 18th year, what they go through, the things, I mean, you are supposed to know as a health worker. Okay. So the growth side and the development side. Under the development side, we looked at the psychological side, okay, where we did the psychology or the psych relating to the society, their sexuality, and their mind itself. Okay, so the psychosocial, the psychosexual, and the psycho or cognitive. Okay, yes. So, and I have intentionally added a bit of those ones to this slide. Just that when you take this slide, everything is embedded. Okay. So if you look at the growth and development, is very heavily tested. Please never joke with this slide. Okay. Yes. We have the developmental stages, which we did. This is a concise format, kind of a crashed form for you to understand those who have their ATTs and they are willing to, they are ready to write the exam. When you take this slide, you will know how it goes. Okay. So everything you need to know, infants, toddlers, preschoolers, what the exam, especially NCLEX, looks at. Okay. Then we have the development side, the high yield. So Erickson, the PAGs, that the cognitive, the sexualities, what goes into it. And we have the Kobeck. Okay, that's the morality aspect. Then we have some key concepts you need to know, okay, that will also help you with your priorities. Then we also look at what? The vital signs, pediatric vital signs. So this one will help all nurses. So as you are managing children on the ward, their heart rate, their respiration rates, their blood pressures, their temperatures, okay. This is their normal ones that you need to know, okay. and it goes on and on. So an infant will have heart rate of this, a newborn too will have. As you age, then the heart rate is dropping. Okay. As you age, then the heart rate is dropping. It will drop. It will drop if you then you mute yourself. Okay. If you drop, if as you are aging, then the heart rate is dropping. So it will drop till you die. You keep growing till you die. So it's like a cycle. Okay. It's from the up. You are here. You are day zero, and your heart rate is super high on the high side. So as you are aging, today you are 1 year, the heart rate will come down. Tomorrow you are 20 years, the heart rate will drop. Tomorrow next you are this. So until you become a full adult, one day you die. And definitely when you die or when you get cardiac arrest, the heart rate is zero. And everybody who dies on earth gets cardiac arrest before they die. Okay. So at a point, one day your heart rate will be zero. So that's what you should know. Okay. And children, respiratory rates are the earliest indicator of what? Distress in children. That is what you should know. This is a pearl. That is why I've highlighted it. Why? Because children, when you take the respiratory system of a child, though they have a lung, but this lung, yes, the mother was able to give birth to the child at 9 months, whatever, so a full term, okay? But we can't superly and overly trust their lungs when it comes to respiration. Yes, they have mature surfactant and all this, but the lung muscles, the muscles, the breathing in and breathing out, helping it to, and the ribs and all this, we can't 100% trust it. So God or the creator has made it in such a way that a baby or a child uses most when it comes to respiratory muscles, they use the diaphragm. Okay, 2 seconds, I'm coming. They use the diaphragm. Okay, children use as we go down or as we move ahead, you understand it a lot. So when this diaphragm collapses, trouble has come. Okay, yes. So these are the things you should know. The pain scales. So as you are doing your assessment, remember, we have a general assessment we do aside the APGAR scoring. Okay. So as your assessment, children 0 to 3 years, you can't use numeric. They don't talk. They can't express themselves. They cry. So you use the non-verbal cues, okay, to assess whether the child is in pain or not. So we have the FLAC. The FLAG system is an acronym, it's the first letter of words. So the AF is the face, the L is the legs, the A is the activity, the C is the cry and consolability. Okay. So if you look at their face, I mean their facial expression, when somebody is in severe pain, the person will not cry, will not smile. Okay. Their legs, look at their legs. Somebody is in severe pain, the legs will be moving up and down, distress, kind of. Okay. Activity, are they relaxed or hyperactive? They are having discomfort. Okay. They cry or there is no cry. So all these ones will help you to know. Then as they are crying, as they are in distress, you carry them, put them on your shoulder. Oh, baby, 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 calm down, calm down. Are they consolable? Are you able to calm them down with just normal touching and hugging? No. Okay, that means they're hot. They are having hot this pain. Now, as you age, you enter age 3 and above. So age 3 and above, or mostly age 3 to 6, which these people, we say them preschoolers. Okay, the preschoolers, yes. So the preschoolers, yes, they are able to express but we mostly rely on faces. Okay, their facial expression. Their facial expression. We don't use flag again. We use facial expression. The child points to the face that matches pain. So when you go to the hospital, we have different faces for pain. Okay, we have one face that is smiling, one face that is steady, mm, one face that has frown, one face that is crying with tears. So the child, preschoolers, they are able to point that, okay, this face is, this is my pain, this is my pain, this is my pain. Okay, and then you also know whether to give them pain meds or not. Okay. Then 7 years and above, the school age, from school age, class one. To 10, where zero means no pain. This one is superly or high pain. And five is what? Medium. Okay. How will you rate it? Then they will tell you. Okay. Yeah. So these are the things you should know. Mhm. Okay. So pediatric assessments too, we did it, but I've added it to this slide so that you understand it more. So the general assessment head to toe on the head of a child who is born, you see you as you are pressing or you are feeling the head, you get to a point that it will be hot in then there is no bone there. Okay. So these ones we call the fontanelles. So you have the anterior and the posterior, which we know. So the anterior closes to 12 to 18 months, and the posterior will close at what? 6 to 8 weeks. So when it bulges, mm, this is my head. This is a hole here. This is the skull. And under it, we have the brain tissue. Mhm. We have blood. We have cerebrospinal fluid. Okay. Any of these three, when it goes up, and what give me intracranial pressure, and it will make the brain become bigger. Okay. Yes. So when this one swells, when you palpate this point or this point, mm, the fontanelles, you will feel that the fontanelle has bulged, or sometimes even looking at it, you feel that the fontanelle has bulged. That's why the health workers always advise that when you give birth to children, they should have what no hairs so that you'll be able to assess their head, their circumference of the head, and to see. You can see because children with plenty hair, you can't see their fontanelles whether it unless you patch the hairs and you go and observe it with your eyes. So when they have uh, increased intracranial pressure, but in situations where this fontanelle will sink, it means that what either the brain tissue has shrunk, either there is less blood supply to the brain or less amount of cerebrospinal fluid. Okay, so we mostly say dehydration. Where would dehydration fall under this three? Under the blood. Okay, under the blood. So you see your being and all those stuffs. Okay, your hematocrits taking different shapes and values. Okay, now let's look at the reflexes. Children, we say sensory motor. Everybody developed or grew from sensory and motor. Okay. If I take a child and I throw the child up, okay, the senses will work, the motor nerves too will come in. Okay. So these are the things you should know. So there are some primitive reflexes, like the primitive means, primary, started with life. So primitive reflexes comes in. Example, the Monroe reflex. They disappear 4 to 6 months. They should disappear. The routine will also disappear 3 to 4 months. And the Babinski, when we were learning the other slide, we saw all these reflexes. So the Babinski is what? Until 12 months. Then it also vanishes. Head circumference of the child, baba the hair or remove the hair, is measured until 2 years. This one reflects what? How the brain of the baby is growing. So when the head circumference, yesterday you went to measure the head circumference, it was 20 centimeters. Another 3 months, you've gone, or 1 month, you've gone to measure again. It is 100 centimeters. What's up? What is going on with the brain? That the hair circumference has, because the bones of the child they are just in a position with each other. They are not strongly fixed or attached to each other. So when the brain swells, okay, they give way for the head to be big. So head circumference becoming big, too big, we always blame what? Hydrocephalus. Okay. And when the head circumference is low, we call it what? Microcephaly. So these are the things you should know. Then we have the WHO chart and the CDC chart. Okay. So WHO will say that birth to 2 years, or sometimes 1 year breastfeeding. Then CDC can even say that, you measure the growth of the baby to greater than 2 years. Yes, that is what CDC also can. These are all institutions in the world that helps us to monitor children as they are growing. So these are just a bit of just rushing through so that you understand it more, because we've already done this. Then pediatric safety and emergency. So those of you who are going to write exams, you should take note of this topic. Pediatric safety. So children, infants 0 to 12 months, you should pay particular attention with how they sleep, because they are prone to sudden infant death syndrome. So the other time Victor was mentioning about this. Okay, then their car seat. So this is one. You should pay more attention to their sleeping position, how you put them in a car seat. Then choking is very important, okay, because they are orally fixated. Poisoning is very important, orally fixated. Burns is also important. So these are the things you should look out for, okay. Children should always lie at their back in the supine position, firm mattress, no pillows or blankets, room sharing without bed sharing. Yes. So they should sleep in the same room where their mother and the father is sleeping. But the mother and the father should not put them in between themselves. Either the mother will sleep on the child or the father will sleep on the child. So we always say that room sharing and not bed sharing. So take note of that. Room sharing, not bed sharing. Okay. Let's go on. Toddlers. Where should we focus on when it comes to safety? So toddlers, we are looking at falls. Yes. Toddlers are now walking. 12 years, you should now be walking. So 12 months to 3 years, or 1 year to 3 years, toddlers. So falls, they want to try everything. Yesterday we learned about them. They want to try their autonomy. Autonomy versus shame and doubt. So they want to try everything. So they will try to climb the stairs, fall down. Okay. Windows, they will try to climb it. If you are not careful, they will flip over and fall on the outside of the house. Choking is also another problem for them. They don't want you to feed them, they want to feed themselves. So they before you allow them to feed themselves, make sure you cut the food into smaller pieces. Why? Because children have small airway compared to adults. Okay, so they can easily hurt, choke. Poisoning, curiosity will always cause issues for them. Okay, so you lock your cabinets, all these organophosphate materials in the house, this Dettol, these parazones, all these ones, you lock them under cabinet. Mm. If in case they take some, poison control is very important. This is poison control. When we say poison control in the US, we mean it's an institution, okay, that anybody who takes poison or overdose of medication, you have to call them. So when you take this child to the emergency room or the hospital staff should call the poison control. And the poison control will tell the hospital staff what to do and how to manage you. And until poison control clears the child or clears the patient, that patient is now safe to go home, the hospital cannot discharge the patient. So that is what it does. Everybody should know this. Then drowning is another important thing with toddlers. Yes. So drowning, never leave them unattended near water. Preschoolers, their major problem is burns. So you need to teach them. They understand some simple things in life. Teach them what is hot, what is cold. Then you supervise kitchen use in case you want to take them to kitchen. Bike, use helmet always. Then fire safety is also important. Okay. Now the child has started primary school, stage 1 to 6 or 6 to 12 years. You look at sports. Yes. They are going to school. They want to share, they want to play with their friends, sports, football, and all those stuffs. Okay. Water safety is also important because the school has been teaching them all this swimming and all those stuff. So when they come home, sometimes they want to go to the pool themselves and all those stuff. Then firearms. Mhm. Yes, ammunitions. I added this because in the US, gun is legal. Everybody can use gun. Yeah. So if you are a parent, you have gun. mm, you should lock it. You should unload it. Take the bullet out of the gun and ammunitions always separate. Put them at a separate place. Don't let these children get access to. Okay. Adolescent identity versus what? So they have identity issues. Identity versus role confusion. So identity, they want to be seen and recognized everywhere they are. So you see them, they want to drive their father's car, they want to ride their father's motor and take it to school, take it to park. Okay, their father has a car, 15 years old. In United States, 15 years can drive. Okay. 15 years and 13 years can look after their junior siblings. So it's legal here. So I don't know your country. I don't know where you are watching me from, but motor vehicle safety for adolescents. So teach them, yes, you can drive or ride my motor. Put on your seatbelt. Don't test when you are operating these machineries, and don't drive or do, drink or drive, drink or do drugs when you are driving. Okay. Then you do your substance education, substance use, marijuana, cocaine, amphetamine, methamphetamine, fentanyl, tramadol, all these educations you need to give to them. They want to try everything. Then firearms, like the way we did it for these guys, you should also store it safely. So these are what? The safety aspect. Now let's go to what? Abuse. Abuse in pediatrics. Okay. So in abuse, if you abuse a pediatric, it is mandatory reporting. If we assess and we see positive, we get positive check mark that this child has been abused, the parents must what be handed over to the police, okay, and make it what a legal issue. And the police will take it to court. So the legal issue. And when it goes to court, it becomes criminal offense. And the court will make sure that they put this offense on your file, that you are a child abuser. So in future, if Vivian wants, because I'm seeing Vivian, if Vivian wants to apply to become a teacher, they will say, Vivian, you don't qualify to work as a teacher because teachers work with people who are vulnerable and children are vulnerable. Why? Because Vivian has a bad record, a past record of what? Child abuse on her. Yes. So everything that is put on your file, in UK, they call it DBS. Okay. So everything that is put on your file, everybody will see. Okay. In Ghana, we call it police reports. So these things are, what are why are health workers learning child abuse and neglect? Because child abuse and neglect is part of the mandatory reporting issues in this world. So a parent will bring the child to the hospital. It is the nurse that will take care of the child first. Okay, so if the nurse does not know what are the signs of abuse, the parent will take this child, come for treatment, take the child home. Meanwhile, the parent has beaten this child. Meanwhile, the parent has neglected the child went to injure himself. Okay. So the nurse must know and report the parent or the issue to the police. So every hospital has a police. Okay. And the hospital I work, always police is back at the ER. Okay. So the listing, you just take your walkie-talkie or your phone, call them. Yes. And they will come and arrest the parents. Okay. So that is what goes on. Physical abuse indicators. So what will show that this child has been physically, that you can see with your naked eyes on the skin that this child has been abused? You see bruises on various parts bruises of various staging of healing on the skin. There can be injuries inconsistent with the history the parent is telling you. So a child was brought to the hospital with what? How do we call this term? A black eye. A black eye. Let me show you black eye. Okay. Let me show you black eye. Because we see it a lot in kids. Let me show you. This is what we call black eye. So have you seen this? This means that the brain inside the skull has been injured. How come this child? So the cases like this, police must know immediately. Or you, the nurse, you ask what happened at home. Then the parent will tell you a story. It could be that the parent has slapped the child. The parent has physically abused the child, and he because the child cannot talk, or because the child cannot express him or herself well, or because the child is afraid of the parent, they will come and tell different stories and take treatment. This one, you do CT scan of the brain. Okay. If you miss and you let this situation cross, the parent will take the child home and the abuse will continue. So that is why we need to report for the police to come in and investigate. Okay. We have the criminal investigating department. They have been trained with investigations. So how to do investigation. So they will go deep, dive deep. They will call the social workers to come in. They will come to your house and know what is going on. So these are some of the things you should know. Okay. Yes. Then, and don't tell the parents that I'm going to report you to the police. No, we don't do it like that. If you are the nurse and the parent brings the child with signs of abuse, you don't say anything. You collect your data. The nurse is a data collector. Collect it. When you finish, give them a room to stay. Okay, they are in their room. Okay. Now you go to your ward in charge or your charge nurse and tell them that you want to report an abuse. Okay. So they will take it, and either you or your ward in charge will call the police without the parents knowing. So treatment and everything will be given to the child, but when they are leaving, the police sometimes you tell them, the ward in charge will tell them that this issue has been reported to the police. Don't tell them at the beginning of healthcare. Tell them after. Otherwise, the parent can run away and leave the child. So tell them after they receive treatment and they're about to be discharged. Then you tell them that this issue has been reported to the police. So they should be expecting the police. Okay. Yes. So that is it. A child has been sexually abused. How will you know? Difficulty walking or sitting. So genital pain, bleeding from the vagina or the anus. Okay. Discharge. Age appropriate sexual behavior and sudden behavioral changes, sudden fear, sudden that all of a sudden the child doesn't want to get close to people again. All of a sudden the child doesn't want to wake up, sleeping, and all those minor signs. That should give you what indication that this child has been sexually abused. Then shaking baby syndrome. It is something that all of us do it. You can be reported. Okay. You give your child to somebody in town, and the person will be shaking the child like this. Okay, shaking like this. Okay. You are shaking the brain against the skull. It is one of the issues of black eye. You thought you were just playing with the child, but you have caused trauma to the brain. Okay. There can be retinal hemorrhage. There can be subdural hematoma. Somebody took your child in town, shake the baby. You were not there. Now you went for your child because you went to work. You went for your child, brought the child home. 2, 3 days, 1 week, the child is having what? Retinal hemorrhage or bulging fontanelle or having seizures. Just normal seizures. So this child wasn't like that. What caused that? So this child must be brought to the hospital. You come. My child is having seizures. I don't know what is happening. So we will do our normal assessment, take bloods to the lab, take the baby to the CT scan, do a scan. We will do the EEGs and all those investigations. When it comes out that there is a crack, there is an injury. A baby cannot just sit down and all of a sudden there is an injury, there is a crack to the cranium, or there is a crack to the skull bones. Something has happened. So in this case, the story, the history the mother brought, and the evidence we are getting at the hospital is inconsistent. Okay, it doesn't meet, it doesn't relate. So the police must come in. So you, the nurse, you must what report. They call it mandatory reporting. What if this parent or this parent is your pastor in church? Will you report or not? What if this is your assemblyman? Will you report him or not? Because you, the nurse, you know where it will end. Okay. So if you cover it and they catch you, the nurse, your PIN will be taken, your license will be taken from you, and also you can be jailed as a nurse. So be careful. In hospital, there is nothing called friendship. We are colleagues. We are not friends. Two friends cannot work in the same hospital. That is the deal. Take note. If you want to work in abroad, nobody is your friend at the hospital. Everybody is your colleague. You nursing action. So you stabilize the child first, then you report suspicion, not proof. See, you don't need proof. You don't even need proof. The law allows us as health workers to report suspicion. The mere fact that you suspect, report it. Whether it comes out as true or false, you don't care. Nobody will do anything to you. Okay. Yes. Nobody will do anything to you. So report. But because of your own safety, because you live in a community, you are a traveler, you were posted to that town. Okay. You live in a community that the parent and the child or the parent grew up from there. So they know the community and they know people there more than you, the nurse. If they come to your hospital and you report them to police, they can harm you when you go home. That is why when you are going to report, don't tell the parent that this is what you are going to do. Okay. This is what you are going to do. So these are the things you should know. Follow institutional and state laws to report. If you don't know how to report, if you don't know the procedure or the protocol, tell your ward in charge. Okay, you go and continue your work. The ward in charge has been trained to do that. Okay, if you have any question, keep it. When I finish, you ask me. Okay, nutrition. Let's go to nutrition. So infants, what type of food are they supposed to eat? Breastfeeding versus formula. So breastfeeding is recommended exclusively for the first 6 months. Why? Because this breast milk, it provides antibodies. You want your baby to fight infections. That infections prevention or the antibodies, the breast milk boosts your baby's immune system to produce more B and T lymphocytes. The lymphatic, those of you who joined the lymphatic system class, okay, then when these antibodies grow, become plenty, they fight any infection. Okay, yes, bonding and all these ones. Now, formula. If you want to give formula, the formula should be iron fortified. Okay, yes, this is an acceptable alternative when breastfeeding is not possible, but try your best to do exclusive for first 6 months. Okay, iron is very important. Iron is needed by hemoglobin. Mm, iron is needed by red blood cells to produce hemoglobin. So when you take hemoglobin is full of iron. That is why when your iron goes down, you get a condition called iron deficiency anemia. because hemoglobin is full of iron. So if this baby is getting anemia issues, you should check for iron. Okay, those of you who have cancer and all this iron, sometimes they struggle with it. They go for iron infusion and all those stuff. Vitamin D is very important. Mm. It is required for breastfed infants. So you can do 400 microgram per day. Okay, IU. Okay, it prevents rickets because vitamin D will activate calcium. Okay, calcium is needed for strong bones. So if this child is not having enough vitamin D, they will have issues with bone formation rickets. Okay, so this is what you should know. Then, 4 to 6 months, the infants have iron stores until 4 to 6 months. Then iron fortified cereals and formula needed after 6 months. Okay, to prevent IDA, iron deficiency anemia. When do we introduce solids? At the beginning of 6 months, when baby can sit with support, tank, thrust, okay, rolling and all those stuffs. Okay, once one food at a time is very important. Then you start with, like I said, your iron foods. Okay, so NCLEX must come, will come in that this is a trap. Don't give the child below 1 year honey or animal milk. Why? Because this honey and this animal milk, they have some microorganisms you can't see with your eyes. Those microorganisms are what? Infectious agents. They can go into the child and cause a condition we call botulism. Okay. So this child will be having abdominal discomfort, issues with digestion. Okay. They will have issues with digestion, abdominal discomfort, and all those stuffs. Nowadays, people have taken advantage of this and they are selling gripe water. And why should you let your child get botulism before you go to the pharmacy to buy hot? Or why should you let your child get indigestion before you go and buy hot gripe water and all those uh, substances? So that is what you should know. So nutrition, I mean, this is how when you get a slide, you know it. I want us to go fast on this. Okay. You want to prevent obesity. So you should limit sugar and drinks and screen time. Let them play. Screen time will let them sit at one place. They don't walk, they don't do anything the whole day. They don't burn calories. Okay. Yes. Then picky eating, toddlers and preschoolers. Yes, they like picky things. Then special diet. So children with celiac disease, we will do celiac going down. Okay. We have some people who have issues with a certain substance in food we call gluten. Okay. We call gluten. When the DNA or the cells of the baby does not like this gluten, and you give food or you give them gluten, where they will develop a certain condition we call the celiac disease. Where can I find gluten? You find gluten in wheat, barley, rye, and all this one. Then we have another condition that children mostly struggle with. Some children, we call it the phenylketonuria. Phenylketonuria. It is caused by high amount of a certain vitamin. We call it what? Phenylalanine. So you reduce phenylalanine, okay, which is avoided in what? high protein foods, and aspartame. So all these things you do. So NCLEX can give you a question on this and add some of these things through it or as part of the options. When you choose that, it's a trap. They don't want you to fail, but they want to know whether you know what you are doing. So do not pressure children to eat and assess growth trends instead of daily intake. Okay. So look at hydration, pediatric fluid, and electrolyte balance. Yes, they also have fluid and electrolyte balance, intake and output. How will you know that my child is what? Is well hydrated or dehydrated or moderately hydrated? Okay. And what are some of the causes of dehydration in children? Vomiting, diarrhea, and fever, and poor intake. Mm. Inside your stomach or your GIT, there is high amount of chlorine and electrolyte. Take note of this. We'll come back to it in future. Chlorine and electrolytes. Okay. The GIT is divided into two. We have the upper GIT and the lower GIT. The upper side has a lot of, because of the stomach here, it has a lot of hydrochloric acid. So when you vomit or when you regurgitate, this acid sometimes can burn the inner lining of the esophagus. Okay. Or when you vomit, you see a lot of acid in it. Vomiting a lot means you are losing the acid concentration. So your body, if here is 10 acid and here is 10 base, now you have vomited the acid out. Sorry. So now you have 2 acid and 10. Okay. So your body will switch into a certain mode. We call it what? Metabolic alkalosis. Because acid has reduced and vice versa. It goes that way. Below the GIT, lower GIT has a lot of base. So when you poo-poo, we are taking out a lot of base. Okay, so the reverse becomes the case. So all these ones has, whether you poo-poo, whether you vomit, whether you don't take in, it has some amount of fluid. Okay, and also electrolyte. So you are losing fluid. You think you are vomiting, you are losing fluid. When a child is mildly dehydrated, he will test slightly dry mucous membranes. So they lose weight, mostly less than 5% of their total body weight. You should know the weight of your child and the height. It should be on your fingertips, like the telephone number of your partner. You should know your partner's telephone number. The same way you should know what your child's weight and height. Okay. Moderately dehydrated, they have sunken eyes and fontanelle. Urine output. Now the kidney is involving themselves. When you are mildly dehydrated, the kidney leaves you, do what you like. But when you are moderate and severe, the kidney will involve themselves. They will not allow you to urinate. So blood will be passing through the kidneys, but the kidney will never filter it. Even it will filter the blood, just a little amount, then it allows the rest to pass. What will happen if the kidney is not filtering? You are not getting urine in your bladder to urinate out. So urine output will go low. So when your urine output is going low, you should note that now your dehydration has moved from mild. This one goes for adult and whatever kids. Your dehydration has moved from mild to moderate. Okay. Don't let it go severe. The kidney will shut down. When the kidney shut down, you get a condition we call acute kidney injury, aka you are in the acute phase. Okay. Right. So this is what it goes with it. The heart will try to compensate with tachycardias, to push fluid to the system. Okay, and all those stuffs. So children deteriorate rapidly. Assess urine output and respiratory rate. Take note. We started with respiratory rate. Now we have another addition. So let me highlight it for you. Okay, and you get it. Those of you who are having this slide, I've updated it. Okay, so in medicine, yes, anatomy A is A, but when it comes to physiology, A is not A. Every day, new updates come. So you have to learn every day. Join groups that will make you learn so that you always update your knowledge. So I've updated the slide, so take notes. Now, oral rehydration is also important here. That is the first line for mild to moderate. In severe dehydration, don't go and give ORS. Okay, you go IV. So mild to moderate ORS, oral rehydration. Okay, yes, we can go to the drugstore and buy it commercially. We have some, but we have bottled water. The bottled water, you see these pure water girls selling on the street. There is some bottled water. They have electrolytes in it, solely for children. Okay, solely for children. So it is electrolytes plus water, solely for pediatrics, children 0 to 18 or 18 to, children who can take water and all those stuffs. Okay, so we call it what? The Pedialyte. Yeah, Pedia. Then we take the light, electrolyte. We call it Pedialyte. You can buy it like pure water in a bottle. Then you take Pedialyte. You take like drinking water, but don't make it a commercial, like something constant for your children at home. They should drink free water. A water with less or low electrolytes. We call it free water. Take note, know the difference. So when you are going to give IV fluid and the doctor say give free electrolyte, it means some free water. Sometimes they are saying this 5% dextrose. Okay, so water and sugar. Just that. Okay, no electrolytes. You go your way. Okay, Pedialyte. So this is what you should know. Make it small amount, frequent amount. Then you continue your breastfeeding. Avoid water only when you are having dehydration issues. No free water. Add electrolytes. The child is vomiting, poo-pooing. Avoid juice, okay? And avoid soda. Soda has a lot of sodium. Dehydration and sodium are not good friends. Okay. The cells, and this is the cell. So the cell is starving. Eh? It's starving of electrolytes or water. Then you go and put sodium in the IV. It will take all the water to itself. Everywhere sodium goes, water follows, and the cell will continue to starve. Okay, so that is what you should know. Avoid soda. Okay. Then IV fluids are always isotonic first because you want the water to stay in the hot. So these are the things you should know. Electrolyte imbalances in children. hyponatremia, low sodium. We have the cause is more free water, hypotonic IVs. Signs and symptoms in children, you see headaches, nausea, seizure. Sodium going down in the blood, your seizure precaution is very important. Seizure precaution. Let me highlight this for you. And slow sodium correction. Don't move it fast, otherwise it will move all the water from the cells to the intravenous. Potassium in a child has gone up. Okay, it has gone up. Potassium 3.5 to what? 5.0. It has gone up. Okay, what causes that? Is the kidneys allowing is the kidneys allowing the electrolytes to go out, or there is a kidney failure that is causing the buildup? Potassium is leaving the cells to the blood. Is there acidosis, metabolic acidosis, that is causing what? There is so much tension at the tissue cell level that potassium is leaving the inside of the cell to the bloodstream. Has a tissue or a cell broken or cut into pieces? So this is a cell. Inside the cell is potassium, outside the cell is sodium. If I take a knife and cut this, how can this cell cut? Somebody got an accident, the skin is torn. Somebody got an injury, the cell is torn. The potassium will leave this and come to the blood. Okay, and cause what? Hyperkalemia. So what are the signs and symptoms of hyperkalemia? Muscle weakness, ECG changes. Okay, so in hyperkalemia, you always what? Your priority, I need to highlight this for you. Your priority is what? Let me make it red. Okay. Your priority is what? Cardiac monitoring. Electrolyte, cardiac monitoring. Okay. The cells are leaving, potassium is leaving the cells to the blood. Should we allow the potassium in the cells of the heart to also leave and go? No. So how do we stop it? This is the blood vessels. The blood vessels has muscles. The tissues, your hand, your leg, your thigh, your stomach, all those ones are called tissue. The muscles, they are here. And this is your heart. They also have muscles here. Okay. This one has potassium inside. Here has potassium. 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 All these cells are dying. The potassium is running away to the, when cells die, potassium will never stay with you when your money finish. There are some people, when they are with you and your money finish, they will never stay with you. Potassium will never stay with the cell when something happens to the cell. When there is an accident and these cells break, potassium will run away to the bloodstream. Even the blood vessel that is carrying the blood, when the muscles of the blood vessel make loose and something happens to them and their cells, potassium will run away from them and go here. When potassium leaves you, a man, let me tell you this story. A man who is very rich used all his money to look after his wife, and now the wife has left him and run away. Do you think this man will have energy again? No, that is why in hyperkalemia, see, hyperkalemia, it means that potassium has run away from somewhere and they have run away to the bloodstream, the blood vessel. So the question is that, where is this potassium coming from? You are in your house. All of a sudden, a child will run into your house. Help me, save me, save me, save me, save me. Where are you coming from? That will be your first question. Okay, where are you coming from? That is why when you go and seek asylum, they don't sack you. They collect your passport and they will make you what? A permanent resident of whichever country you are seeking asylum. Because why are they collecting your passport? Because they don't want you to go back. Okay, that is it. So these are some of the things you should know. The potassium are coming from so many places. Is the kidney dying? Are the muscles dying? Okay. Now, potassium has run away. There is a generalized running away of potassium into the bloodstream. Will allow the heart to also release the potassium to the bloodstream. Because when potassium run away to the bloodstream, the muscles, a man that a woman has collected all his money and ran away, the man becomes weak. That is why hyperkalemia causes what? Muscle weak. This is something you should never forget for the rest of your life. Hyperkalemia. So you have two jobs to do. How can I make this man stronger again? That is, how can I make the muscles strong? And how can I prevent the potassium from running away from the muscles of the heart to the bloodstream? Three jobs. Number one, I have to give a certain medication that will let this potassium go back to where it was coming from. And once they go back to the cells, the cell will gain energy and strength again. That is one. Okay. So what are the medications? I can give what? Insulin to drive the potassium away. Okay. And there are other medications. Okay. Now, potassium, some have gone. The muscles are having strength now. Okay. The patient is no more lethargic. The patient is no more weak. But you check the blood sugar, the blood for potassium. Potassium is still high. Will you keep pushing potassium to this side? No. So the excess potassium that we don't need again, what can we do? We need to give a certain medication that will let this patient poo-poo it out. Okay, poo-poo the potassium out. So we go in for the chiazolate. How do we spell it? Chiazolate. So that this patient will poo-poo it out because the patient has muscle strength. Okay, but still there is more potassium, excess. After giving potassium chiazolate and you poo-poo, I will check the potassium again. If still there is more potassium, then I need to what? Dialyze you. Put dialysis, mechanic. I have to use machine to remove the potassium from the bloodstream. We call it dialysis. But before I do all these things, I told you my first thing I'll do is to protect the heart. Because once potassium leaves the muscles of the heart, the heart will collapse. You get what? Cardiac arrest or arrhythmias. Okay? You get arrhythmias. Why? Because hyperkalemia, you see those of you who will be going to message, doing telemetry or ICU or ER, when you look at your EKG, you see a normal contraction of the atrium, a normal ventricular contraction. Okay. The team that says that the ventricles should rest, or rather not be resting, they will be high, tall peak waves. Why? Because potassium has run away. The heart does not have strength to pump. So I don't have strength. Okay, we have all gone to work. Mm. The work is too much. We are not done. Okay, you want to go and rest. Will you allow this worker to rest? Okay, so this is the ventricular contraction, and this is the ventricular resting. But there is muscle weakness across. And this ventricular contraction and ventricular rest, they must work together so that there will be what? Enough cardiac output and blood will go to every part of the body. Now, the ventricles, the resting part of the ventricle has come that it is break time. They want to go and rest. This guy will be so angry with it that, hey, what are you doing? Master, there is plenty work to us to do, so you not rest. So this one will energize this. So even the time the ventricle is supposed to rest, you will see it peaking, tall peak T waves. Okay, so how do we prevent this potassium from going out? We give a certain medication. We call it what? Calcium gluconate. Calcium gluconate. Okay. This calcium will bring energy to the muscles. And this glucose, the glucose aspects will also bring energy. In the same way, these two, when you combine it, calcium gluconate, they give some protection against what? The membranes. When you take every cell of a living being has what? A cell membrane. We did it in science, so you should know. A plant cell has cell wall. You did it in primary. And an animal cell has a cell membrane. And potassium is here. If potassium wants to run away, is it not this place that it will pass and go out? So if I protect this, I create an extra layer of protection. Can potassium go out? No, they can't go. That is the work of calcium gluconate. So your priority is to first protect the heart. Okay, that's just by the way. We did a little physiology. Okay, then your insulin and your glucose coming in to make sure everything. Then metabolic acidosis. So children are not allowed to get. Don't allow your patient who is a child to get electrolyte imbalance. Okay, because if it does, you might have any of these troubles to tackle. Let your shift be nice. So acidosis, there are plenty acid and positive ions, plenty acid in the cells. What is causing that? Okay, plenty acid. The patient, well, okay, let's go to the GIT. Plenty acid in the cell. What is causing that? I told you there are plenty. This is a store, and this is a store. Okay. Anytime you get light out in your town, whom do you call electricity? The first thing you go and check, you check your next door neighbor. Are you having light? Then they say yes. You go and check another street. Is there light? Oh, okay. So there, I'm the only one having problem with my light. So let me call the electricity people. So when you come here and there is acidosis, you first go to your store in the body. Where are the stores? So you check. Is the patient vomiting? No. Oh, okay. So the acid here is secured. Is the patient pooping? Yes. Diarrhea. Okay. Oh, okay. So you are the one causing that. Why are you having diarrhea? Do you have infection? Let's treat the infection. Diarrhea is off. Okay. Have you taken any food that is causing poisoning? Diarrhea. Okay. Let's allow it to come. Hydrate the patient. When the food is out of the patient, patient will recover. When it's becoming severe, let's give medications to stop the diarrhea. Okay. So we'll give all these anti-spasmodics, okay, or anti-motility medications. Then DKE, diabetic ketoacidosis for type 1 diabetes mellitus. Okay, type 1 diabetes. This guy, they always, because they lack insulin, and the insulin is supposed to go to the bloodstream to push the sugar to the cell. Because the sugar is not supposed to stay here, it's supposed to stay here. And what? Insulin. But they cannot go by themselves. They need an Uber driver to help them to cross to this side. Okay. Now, there is no insulin. If there is no insulin, the sugar here will be here. And they will sometimes increase in number here. That is one trouble. But this cell, the cell also needs glucose, sugar, but there is no glucose. So the cell is struggling. Will this cell keep quiet? No. It will tell the liver that, hey, I'm not getting carbohydrate to tap what? Glucose out of it. So go and tell the other food products, protein, and mostly fat, that, hey, convert, fat, convert, and give me sugar. So the fat will say, okay, yes, Amasa, I salute. So the fat will convert itself and give the cells sugar. Okay. But this fat converting to sugar, gluconeogenesis, they have a byproduct which is called ketones. This ketone is a positive anion that makes it acidic. Okay, and all these things will happen at the cellular level. So the fat is being converted to sugar. And the sugar, and some of the sugar that is converted, some will stay here and the extra will be taken to the bloodstream. So there's more sugar. So when I go to your bloodstream, sugar is building up. When I come to your cell level to ketones, it's also building up. Okay. So two troubles, one God. This acid will dominate the cells of the body and switch the body into what? Acidotic level. Okay. So in excess, the body will find a way to excrete some of these. Okay. So in excreting, because it will come, sometimes it excretes through the urine. Okay. It excretes. If I take your blood to the lab, I will see ketones in it. If I take your urine, I will see ketones. Some of them will climb to the lungs. So they have to be excreted out through expiration, breathing out. Okay. But the cells of the lungs and the respiratory system, because they are dominated by this acidosis, will weaken it. it will weaken the respiratory strength. So you see that the patient will get what? Weak respiratory strength. And also, but they have to excrete this one out. So they will expire it out, and you have that smell, that kushmal smell. Okay. So the kushmal breath, sorry, the rhythm of the respiration will become kushma. Eh? And the breath, when you smell it, it's called acetone. Acetone. Sweet smell. Acetone. The body is full of what? What if you don't see this? You don't see this. Does that mean the patient is not having DKA? Yes. Maybe it has not reached this stage. So you still take your blood, check this. Take your blood, check this. Okay. The gap, there is a gap because this, if you take the pH scale, this is the base and this is the acid. Now, acid has become plenty, so acid has moved further away from the normal level. So acid is here, and this is the center. So if you want to measure the length from here to here, it will be wide or it will be big. And if you want to measure the length from here, the base to this base, it will be small. So if you take the distance from here to here, there is going to be a wide gap. We call it the anion gap. The anion gap. Okay. That is the priority of management of DKA. What is your duty as a healthcare worker? The nurses and the doctors, your duty is to bring this acidosis from here to here again and close this gap until the anion gap closes. You are not done with the management of DKA. So you don't just set up your infusions, give your whatever, and go. No, close the gap. Do you know how to monitor anion gap? If you don't know, go to the lab guys. They will help you to monitor it. Okay. So this is physiology. Potassium is acidosis. Renal failure can cause that. Okay. So pH will go down into the acidosis. So treat underlying cause. Is there infection? Treat it. Diabetic type 1. You give your IV fluids. Yes. IV fluid, your normal saline first. And when the blood sugar goes below 200, you switch from the normal saline to dextrose saline. Okay. Yes. You do your 1 hour blood sugar check. Then when it's below 200, you switch to your sliding scale. So you follow your hospital protocol. Take note. Your insulin breath to push the insulin away. When the blood sugar goes below 200, those of you who don't use the gram per deciliter, you divide this by 18. So you know what to do. Always divide by 18. Okay. Yeah. And so that is it. Now, let's enter into, we have 30 minutes more. Let's enter into the system by system pediatric conditions. Me and you, we have a journey to make. Let us start. The first system we are going to look at, because I've told you that the respiratory system of a child is very important. Okay, so you can't treat a child without knowing the respiratory status. The respiratory system is very important. The abdomen respiratory system. Okay. So know this. Every child has a narrow airway. If an adult's airway is like this, you can eat a ball of and the muscles here are even elastic muscles. So they stretch. So you can do eating competition and take all the ball of fufu and swallow. The elastic muscles here will become wide and you swallow. This child does not have that luxury. They will choke because their airway is small. That is one aspect. Let's look at their tongue. You can't learn physiology, respiratory physiology of a child without knowing these things I've listed here. Those of you who want to become an anesthetist, know this. Don't forget to the anatomy of a child's respiratory system or airway. The airway is narrow. That is one. So the least thing, they get obstruction. The preschoolers, you see them holding a toy, a ball, small, tiny. The least thing, throw them to their mouth. The infants, you hold them, see them orally fixated. Ask yourself that this thing my child is holding and the airway he is having, if in case he swallows it, can it pass through the airway? Okay. Can it pass through here? The least thing, it will choke them. Okay. Second thing, their tongue. You and I, our tongue is small, but a child has a big tongue. An adult has small tongue. You see the beauty of nature. So if your tongue is big, can you roll it back? Now I have put food in my mouth, so I want to roll. No. But this child, adult can roll, can do whatever he wants to do. Okay. Yes. So this one, the mouth is already full because of this big tongue. Let's look at the epiglottis. Epiglottis is a floppy or it's a muscle that covers. You see, a woman knows this very well. When they have a cooking pot, they have the lid that covers it. This is your epiglottis. So the epiglottis is covering your airway. Okay. So when I am talking, I need to talk with my voice box. Trachea, here. Where is the trachea? The trachea is in the airway. So the epiglottis must open so that the air can pass through, in and out. When you are breathing, the same thing happens. Okay. But once I begin to eat or swallow even saliva, I don't need my voice box to swallow saliva. I don't need my voice box. When you are swallowing, when you are eating, you don't need sound to eat. Do you need sound? Ask yourself, do you need sound to eat? No, you don't need it. Okay. So when you are eating, this one will have to close. The epiglottis will close the entrance of the trachea. It will close it like this and open here the airway, the esophagus for the food to pass through your esophagus to your stomach. You see, this muscle here, as you are growing, it becomes hard because God knows in his wisdom, he knows that Adults like eating solid food and all this hard food and these things. Okay, so we need to strengthen the epiglottis. That is a muscle. It has to be strong. Mm. So the epiglottis of an adult is strong, but the epiglottis of a child is floppy. Okay, it doesn't have that strength, floppy. Okay, so the least pressure, food can pass through and go to the airway. The least thing they will aspirate. Okay, the epiglottis. Remember, and this if a child gets streptococcus infection or oral infection, they have poor oral care, and this epiglottis get inflamed. If you are not careful, the epiglottis will burst, it will rupture, epiglottitis, and it will cause severe infection and issues for this child. They will aspirate infections into their airway and they will get pneumonia. Okay, because their epiglottis is floppy. Good. Let's look at the cells of this child. It needs oxygen super, super, super. Why? Because the child relies on what? You know, we adults, when you take our lung, these two lungs, our lung has what? Muscles, and it has ribs. Okay, so this is intercostal muscles. We also have the sternocleidomastoid muscles coming all the way from the neck. We have our abdominal muscles that will help us to breathe in and breathe out. This child, and we also have our diaphragm. Okay, so all these things come together to help adults to breathe. Let's look at the child. The child has all these structures, but they are not strong. Okay, so they only rely on what? Mostly, the strongest of all these muscles for children is the diaphragm. So the least thing, they get respiratory distress. And when they get respiratory distress, imagine you hide the diaphragm of a child. You are killing the child. Yes, they have these structures, but they are not strong. It makes them consume a lot of oxygen. They need to grow. Okay. Their cells are growing every day. They need oxygen for metabolism. We don't do digestion at tissue cell. There is a difference between digestion and metabolism. Okay. There is a difference between that. Take note. So at the cellular level, we call it what? Metabolism. So the cells must metabolize, produce ATP, adenosine triphosphate. Yes, as the end product of what? Metabolism. Okay. So respiratory distress is a priority. When your child gets respiratory distress, don't go and fight the healthcare worker. Take time for them. They will manage your child for you. Okay. Child's airway or everybody's airway is divided into two, like the gene IT. We have the upper respiratory airway and the lower airways. Okay. When these two brothers, they are brothers, Strider and Finn. When something blocks the airway, air is coming down and something has blocked it here, the air will try and force itself through this small area. When it tries to force itself, it will create some pressure sound. like, okay. Yes, that is a pressure sound. When did the pressure sound occur? You, the health worker, that is why you need a stethoscope. Assess the airway. Where did you hear the pressure sound? Is it on the upper side or the lower side? If it is upper, this pressure sound is called stridor. If it is lower, it is called wheezing. Okay, let me now show you the trick. You don't have to learn this. Okay, the trick is that look at A, B, C, D to Z. Eh? You will meet S before you meet W. I am done. So when I want to travel from your mouth to your alveoli, I will meet S on the way. I will meet stridor on the way before I meet wheezing. Are we on course? Are we on the same course? Eh, we have our time is up. Okay. So stridor and wheezing. This is what an airway obstruction sound. So asthmatic is having wheezing in the bronchioles. In the bronchioles. Okay. You are having wheezing because the muscles and the airway, the muscles here, are having what kind of tremors like, okay. Then the airway lining, the mucous lining have become inflamed. And the cells that are holding the mucus, they are bursting, they are rupturing, and they are releasing the mucus. So asthmatic has three troubles. One patient, one God. So this mucus is supposed to come out of this patient. They have to cough it out. So they get what? Productive sputum. As you are coughing it out, we need oxygen to come down. The airway is blocked. So they will be having wheezing. That's sounding here. Wheezing. Okay. Yes. So we have, when as we move down, you will see croupy coughs, epiglottitis, and all this. Then we have asthma and respiratory syncytial virus. Okay. You do all these things. We have 7 minutes to leave. Can we stop here, guys? Yeah. So I've updated it. Okay. Croup is a barking cough. Children get airway obstruction. Their larynx, their trachea, and the bronchioles. Okay. They become inflamed. Air cannot go. They bark like a dog. Barking cough. Okay. So it calls croupy cough, hoarseness, inspirational stridor, which is very Western. Let's come back next week and learn more. Okay. Thank you so much, guys. Have you got any questions? So I am with you. We have now entered into the medical conditions. If you miss a day, pediatrics is going to worry you. Oh, somebody is saying, why next week, sir? Ayariga. Maybe this person is new. Okay, so our classes is Mondays to Thursdays, but sometimes, like this week, we had a holiday for the Muslims. So on Wednesday, we could not meet. So Friday, we met. We have met today to cover up. Okay, that's it. So please, yes, we are here. When you are praying, pray that admit to live long. Okay. If you are not part of the If you are listening to me and you're not part of our WhatsApp group, please join. If you are writing your exams in June or July, please, May is ending. If you are writing your exams in June or July, your NCLEX exam, any licensing exam you are writing, meet the administrator in charge of ATTs, and she will add you. Ayarega has posted the WhatsApp group. We have all other pages, TikTok, and yes, we stream live, Facebook, and YouTube. Yes, it's a free class. Nobody will charge you. Admins will not charge you. The only people you are allowed to charge them is the admins. If you join the page, we don't do any advert apart from health related adverts. We don't advertise anybody's group on our page. It is a free page, but we go by our principles. If you put something there and any of the admins take you out of the group, you are not coming back. So I'm stating it again. Don't post anybody's group on our WhatsApp page. It's not allowed. Okay. You are there. Whatever motive you brought to the page, yes, discipline yourself and stay on the page. Okay. It is a philanthropic project we are doing for the whole world. You have a sister, you have a brother who is a nurse or who is a health worker, who is schooling. Let them join the page. We teach it free, no charge. Okay, no charge. See, people would think that maybe we have connected to these social media platforms teach so that they will pay us. I can show you the account. Nobody pays us for what we are doing. No, none of Facebook does not pay us. YouTube does not pay us. TikTok, we have done this for so many years. We want to reach out to everybody, see that people will join and learn because people are dying. Health workers must learn and know what they are doing. Okay, they must learn. Most of the health workers, okay, there are some conditions when we don't even know our left from right. Come and refresh your knowledge. It's a long time you completed school. 10 years, 5 years, 15 years. Knowledge has improved. Knowledge has progressed. Come and know the new trends. That is it. If you want me, my specialty is ICU and the ER, emergency room. Yes. So come. I like the fast-paced life in healthcare. Let us help people. Okay. My name is Paul Bright. I am a registered nurse. I like to be a registered nurse because it's my hobby and I like to help. As you join the page, if you have any question that you want to, you need directions, put your question there. Somebody will come to your aid. If you are struggling with registering for your licensing exam, okay, you want the process, join the page. Somebody will help you. Thank you so much. Any question? Now the floor is open for questions. 10 minutes. Any question?
Yes, hello, sir.
Yes, ma'am.
Good evening, and thank you so much for the lecture. My question is the Child Protection Service.
Okay.
At what level will the law take the child away from the guardian or the parent? At what level will they do that?
For this one, we health workers, our own is to report. Okay. So, and
Okay.
yes, but the social workers and the police or these legal guys, they also have their check marks. Okay. And they will know that, oh, you have crossed this level. So your child will be taken from you. Or you have crossed this level. Yes. Sometimes they can give you warning because the crime or whatever you have caused, the harm you have caused, didn't cross the level. Okay. Yes. So take note. If you slap your child, it has a code. If you beat your child, it has a code. If you insult your child, it has a code. So all those codes has levels. They grade it. This is a mild, severe, moderate, whatever. So when the act you have you have committed falls under a code that is in severe, they will take your child away. Okay. As a nurse, it's not my duty to know the codes and when the child will be taken from you. The nurse is the data collector. So I collect data and I work on the data. That is it. So the data I collected says somebody has committed an abuse. What is my duty then? My duty is to report. That is why we call it mandatory reporting. It's mandatory. You, the health worker, you don't have any right to hide it. If you hide and you are caught, you can be jailed or your license be taken from you. That's it. After I report, I'm done. The next institution will take up from there. Do you understand?
Yes, sir. Thank you so much.
Okay. Okay. Right. So that is it. Any other question, guys? So we live as I'm talking, we are doing a live stream on Facebook and YouTube at the same time. So Facebook will record it automatically, and YouTube too will record it automatically. Don't worry. Go there, go and watch. Okay. But when you go, like what we are doing. The more you like, the more people see, and they also benefit. Share. Okay. Let somebody see what you are also enjoying. Don't hide it. Okay. Because nobody is charging you. So please, you to help the group to grow. Okay. Thank you so much. Any question? If no question, any other question? Victor, do you have any question? Where are the girls? Do they have any question? So let's meet next week, Monday, for the rest of the journey. And I'll take you through all the systems, system by system. Okay. So we're in the respiratory system. You'll finish the respiratory system and move to another system. Okay. So this is what you are going to learn. Please don't miss class. Never miss class. Thank you. I'm out.
Sir, please, 1 minute, I beg. The vomit and the diarrhea, please. The metabolic alkalosis and the acidosis. Please, I want to The clarity. Is it vomiting for alkalosis and then the diarrhea for the acidosis?
Okay. So let me simplify it for you so that you don't forget again. I told you that your intestines or your GI tract, it starts from your mouth to your anus, but it's divided into, okay. So from the mouth, esophagus to your duodenum, is what we call what the upper respiratory, the upper GI tract, upper GIT. Okay. And from your small intestines, large intestines to your anus is your lower GIT. Because we have a stomach here, it means it's what? It has a lot of hydrochloric acid. Yeah. So it makes this environment acidic. When you vomit, that fluid that comes out as vomitus is full of acid. That's just by the way. On the lower side of the GIT, it has a small intestine, large intestine, full of what? Base. Okay, base. We don't have plenty acid here. Base. Okay. So let's see. This is, let's say I have 10 mils of acid here, and I have 10 mils here. When I check the pH here, the pH, this is the pH scale. Okay. The pH scale is 7.35 to 7.45. Okay. And 7.40 is what the center, but we mostly don't think about those stuffs. Okay. So if this is the center, it means from here to here is the base medium. That is 10 mils, as I'm seeing here. And from here to here is the acidic medium. That is 10 mils per our example. Okay. Remember, children have a certain game. We call it seesaw or tug of war. Okay. Now, Victor is vomiting. So Victor has vomited 7 mils of acid out. So Victor is left with what? Only 3 mils here. Now let's go here. Let's go to this place. This acid which is left here will make this side weak. So the seesaw be like this one will go here like this to here. The base, nothing has happened to the base. The base is still what? 10 mils. But the acid has dropped down to here. So it's 3 mils. So when we take this human being, and this is the center line, the zero line. If we take this human being has automatically switched to the base medium. Okay. Nobody touched. Victor is not having diarrhea, but because he has vomited acid out, nobody has caused, he himself has caused his own what? Acidosis, alkalosis, or low acid level. Okay. So in this case, we will say this guy has what? High base and low acid. Okay. If high base, then it is what? Alkalosis. Alkalosis, alkaline, plenty, overdose. Osis is a medical term. Osis. It came from the word oasis. Okay. That is it. Okay, so how will you know that this is respiratory? This is metabolic. Let me show you the trick. Though we are not supposed to do this today. Okay. Everything, this is a human being. This human being has a respiratory system and all other parts. So, Victor is vomiting. Is Victor vomiting from the respiratory system? Yes or no? Victor, that vomit that is coming out of your body, that you are vomiting, is it coming from your lungs?
No.
Victor, are you there?
Yes, I mean, I said no. It's from the GI.
No, if it is no, then this problem is not respiratory. But the problem is what? Metabolic.
Hmm.
You understand? This is a trick. These are simple tricks to know. This is respiratory, this is alkalosis, metabolic, this, so and so. Okay. Vic, let me set you another example. Vic is getting kidney failure. Mm. And this kidney failure is causing what? His acid to be plenty. Okay. Nothing has happened to the base. So the base is the same normal. Eh? So always, when the question comes, ask yourself, which body organ are we talking about? Our scenario is talking about a kidney. Then you ask yourself, is the kidney part of the respiratory system, yes or no? If the answer is no, then it means that this whole problem cannot be respiratory. It is metabolic. Okay. Then you go and check your acid and the base. Which of them is plenty? Which of them is low? Then you do your scale thing. You're done. We use this one to answer session A questions. Okay. How do we call it? In Ghana, we say session A.
So objects.
Objectives, yes. Yes.
Low.
So you use these things to answer objective. Quick. You don't waste time with your question. But you are gone. So once you are talking to me, I already know the answer. Because a patient is having diarrhea. Okay. Everybody knows that diarrhea is coming from where? If not the small intestine, it's coming from the large intestine or the anus, or maybe the appendix, which is a small structure here. Okay. Are these four organs part of the respiratory system? Yes or no? No. So this is what? Metabolic problem. Then you look at the pH and do your scaling thing. You are done. Okay, let's look at an example of a respiratory issue. Somebody has been stabbed with a knife on the chest. Once I hear chest is part of the respiratory system. Okay. So you have been stabbed. When there is pain, there is no activity or less activity. And because there is pain, he's feeling pain, he will never breathe. So carbon dioxide will not come out. If carbon dioxide does not come out, carbon dioxide will accumulate in the chest. So carbon dioxide is an acid. So plenty carbon dioxide will cause acidosis. Okay. But is the chest part of the GIT? No. Is the chest part of the liver? No. Is the chest part of the brain? No. Where can I find the chest? The chest is in the respiratory system. So this makes the condition respiratory acidosis. Done. Victor, have I answered your question?
Say thank you.
These are
You're making
minor
simple. Simple pa.
minor tricks to know. In some of these questions, I don't understand why they said people are answering the question fast. So they have cancelled their. But if true, that is another topic for another day. Okay, we will come back to that. Okay. And some of us, when we get your question, we know how to jump over it and go. Because champion. I have a special topic on acid-base balance. One day, I'll come and teach you lab values. You take labs from the hair, the tail to the toes. Labs we are supposed to do. So from that day, when you pick up your labs at the hospital, because see, if you want to be a proper gem with healthcare, it's labs and investigations, lab investigations, this scanning. When I say scanning, CT scan, MRI, Doppler, all these scans, USG, abdominal ultrasound, chest X-rays, all these photos, plus your labs. Forget about absorptive treatment. You kill a patient. Okay. Assumption, signs and symptoms. You can't rely on signs and symptoms alone to say that you are treating a patient. Then if that's the case, then we will not have what? Differential diagnosis. The labs and the scans will bring the exact cause. Okay. Because electrolyte imbalance alone can make you have tremor. Meanwhile, because you had seizure attack, okay, you have seizure attack, sodium has gone down. Sodium and chlorine is crashing. Inside your blood, sodium is low. But because you had seizures, somebody is giving you phenytoin. This phenytoin is only increasing the seizure threshold. How about the problem, the actual problem? Okay. So please, let us move on. Let us jump from, we call it assumptive treatment, robotic care, robotic nursing. Okay. A country like US, if they don't do your labs and they don't do your scans, you are not getting medication, forget. That is why they treat you and they will bring your medical bills to you in your house. Then you will tell the hospital how you want to pay it. You want to pay 20 years. Okay, every month my salary, I'll remove $5 and pay. I'll remove $10 and pay. That doesn't mean that tomorrow when you fall sick, don't come back to hospital. Come. So they call their system capitalist system. Okay. If you don't owe in US, you can't survive. So if you fear loan, you can't survive. Because Victor is having headache. He doesn't know what is going on in his head. Victor, come to the hospital. Let us do CT scan of the brain, of the head, and let us know if there is tumor. Victor is saying that I don't have money to pay my medical bill, so I'll not come to hospital. Victor will die, and the system will still run. Meanwhile, Victor would have come to hospital And if they charge Victor $7,000, Victor can say that, okay, this $7,000, I want to pay it in 60 months. So every month plus interest, every month, I'm going to pay, let's say, $50 out of my salary. This $50 cannot even fill your car tank fuel. It's just a peanut. It doesn't mean that tomorrow, if Victor is having stomach pain, he cannot come to hospital. The law allows him to come. That is why when your child is sick and you don't bring the child to hospital, and the nurse reports you, police will worry you. You're doing child neglect. Thank you. Let me stop the share. Okay. So we meet again next week, guys. God bless you all. Invite your friends, invite a lot of people.